All right, Stefan Hartman here, Iron Direct Primary Care, here with Justin Chamberland, my colleague at Iron Direct Primary Care. Justin here has some interesting stories to tell us about his work previously in the ICU and why he's now fully come on board here at Iron DPC and seeing new patients.
Yeah. So thank you so much. It's been a pleasure, and years of working in intensive care, you begin to think that that's the norm, and that people coming in with these chronic health issues, which probably have been going on for 10, 15, 20 years, is just kind of the status quo. And then it wasn't until it really started to sit down with Stefan and starting to see the changes that can be made, the early intervention with good lab work, good diagnosis of seeing how we can start to look at the gut biome, the overall presence hormones. You start to realize that there were early warnings 20 years in advance, but because people just aren't seeing their primary care, they're not following up with a functional medicine doctor, so I would see them in the ICU, and the stories aren't always as positive as we had hoped, so we'll talk about that.
Yes, and even for your own health, working in that environment, you notice some changes, right?
Yeah, full blast, coffee all the time, 14, 16-hour shifts, not eating, and then throwing down 2 donuts. So some of you might relate to that, just that high stress environment, and just not always the most productive.
Yeah, healthcare workers are some of the sickest people I know, and it's just because you're pushing yourself to that level, constantly high stress environment, poor nutrition, and you go downhill just like your patients.
Yeah, absolutely. And I think because of the chronicness of the patient and the demand, and maybe the staffing situations at times, I think you push yourself too far and you get yourself into those situations. I have had many a coworker end up in the hospital bed.
Wow.
Yeah.
And so now you come on board at Iron DPC, you're starting to see patients, and how are you bringing your unique approach to the DPC patient?
Absolutely. So I think, I kind of have and me and Stefan talk about all this time, but just kind of the pillars that we look at, and some of the pillars that we always hear about in life, but you can't always approach, would be the diet, the exercise, sleep as a metric, sun. These are very positive things, and the spirituality and the motivation. Do you have that as well? Because positive thinking does make a big difference. So as we evaluate your diet, which you need to get a lot more specific than just saying I eat my meal or my plate from the government. It needs to actually show what is in the substances and where are the substances coming from, so where you get your product. So it was a wake-up call, and you really need to help people reformat and show them, because it can be overwhelming. The system has really allowed us to possibly just have poor nutritional status, which compounds us in so many ways.
Yeah, the diet part of Iron DPC is so integral, because what you put in your body is what determines your health outcome. And you see someone in the ICU and you're like, they didn't get there overnight, unless it was like a traumatic brain injury or something. Most of the time, it's patients. This was building up for poor habits years and years. No one told them to do anything different. Maybe they went to the doctor, but got put on a blood pressure pill or a statin, but those other changes just never really happened. So you're really, a lot of what happens out in medicine is a symptomatic treatment. High blood pressure is a symptom, right? And you treat the symptom with artificially lowering the blood pressure rather than going towards the root cause.
Yeah.
And you're so huge on talking about sleep too, and that's one metric that is a huge component of high blood pressure.
Huge component.
Huge
component. So, and I want to thank you, because when we first met, me and Stefan were sitting down, and I think we were having a nice meal, and we were just eating some good meat, and we were very fortunate that day. And in a sense, and you've told me about the experiences you've had growing up, which has been powerful for me, about eating and habits that you got to bring into the approach, and that your family supported. And I think that that's so important. So that's one of the things I want to share, is that something I've realized is that the social dynamics, bringing the whole family, or a social development, there's actually a lot of movement now on eating together. So some people can say it's too expensive. Well, you can start to come with a group and you purchase together. Purchasing large amounts, whole cows, all sorts of type things. Actually will probably drive the price down and make you all healthy, and have that positive encouragement so you support one another.
Yeah.
So it makes a big difference.
There's a huge misconception that eating healthy is expensive. It's not the case at all. What's expensive is eating highly processed foods and buying these. These are calorically rich, right? But they're nutrient deficient. So you still get that craving for food, right? And that's your ape brain. It's craving that B vitamin, that NAD, that selenium. That's what your brain is craving. So you're reaching towards those calorically dense, nutritionally depleted foods. You keep consuming this one. So you're going to overeat calories, and you're going to eat more food total, which is going to cost more, but you're never going to get those nutrients. You're never going to get that satiety.
Yeah.
And I think that's also why, maybe it's expensive to live, right? You're eating out all the time, right? That's super expensive. But if you're eating these nutrient-dense foods, you're gonna be fuller quicker. You're gonna feel more energy, and it's gonna, in the long run, be a lot cheaper. To eat that way.
So I was just reading a recent study, and it was really, really powerful. It was about neurotransmitters, clinical depression. It's actually about, NIH is big into this. There is a movement. The government is aware of this, and there are problems with our food sources. So many people with depression take these drugs out there, SSRIs, right? And they'll take them, and it's to take that little bit of serotonin you have in your body and they'll force it into your brain and keep it there, right? But what they're not doing, root cause analysis. Well, we don't need people to keep living with a little bit of serotonin. We need to fill their serotonin.
Right.
Well, serotonin comes from a couple of things: tryptophan, B6, B12, folic acid, right?
Yeah.
You eat those, you create your serotonin. Okay, well that's great. This is good. My sleep goes through the roof. Why? Well, because when I get rid of the blue light an hour before I go to bed, so I shut off my TV, I put down my phone, maybe some breath work, whatever it takes, a cup of tea, and just sit and relax. You go to bed, that serotonin, because of not having that stimulus from the cortisol result from your blue light, actually takes your serotonin and turns it into melatonin. So we've been supplementing so much now with melatonin in this world because we're addicted to our phone and we're addicted to blue light.
Wow.
So really interesting how there are certain metrics. Sleep is a great metric to watch, but once again, root cause is changing that, and it goes right back to our diet. So unbelievable.
That's unbelievable, yeah. And I worked in psychiatry, and wow, that was a pill mill. I felt like a drug lord. It was just see the patient, 15 minutes. Here's the PHQ-9.
Sure.
Okay, you have this score. You're gonna get this pill. Oh, that one didn't work. Let's try this pill.
Yeah.
Wow, that was pretty negligent, and that's how psychiatry is out there. It's just seeing patients every 15 minutes, in and out, give them the pill, chart, bill the insurance company, next one.
Yeah. Now imagine if psychiatry always was with functional. So there are times where we need the therapies and the talking about maybe some psychological traumas. Those are positive.
Yeah.
But the result of, I've always thought this, why is the depression, why is the bipolar, these different diagnoses, why does it increase as we get older, right? Maybe into our early 20s. Well, hormones are starting to change. Things are happening. Our diet has now caught up to us, right? We've depleted it. Pregnant women with their teeth starting to fall out in their gums. Well, it's because of minerals. So they've had a poor mineral diet, they get pregnant, there's a taxing on the body, and the body's going to do something, it's going to take it. Older people with high calcium levels, well yeah, because they're not moving, they're not exercising and doing their muscle gain.
You mean high calcium scores?
High calcium, well that and just the level in general with watching the calcium, because it'll rise sometimes because the actual bone is demineralized.
Oh my God.
So.
Yeah, that's something I saw in the ER a lot when I worked there. It's not slip and fall and break your bone. It's you break your bone and you fall. This happens so often in the elderly population. It's demineralization of their bones.
Yeah, once their calcium's low, it's too late.
And if you can stop some of that aging process, replete the hormones, your bones won't be so brittle. You may not end up on the floor at 2 a.m. and be found 2 days later by your neighbors.
Yeah. Get them onto some more meat diet, get them working out more, which is just a sufficient amount. One that we're trying to work with is a person, Beth Lewis. I really recommend learning about her, but she does kind of functional physical therapy, which is having people do movements like having an old person learn how to get up off the floor with one hand, not two. How many people get stuck on the floor?
So many.
And we see it in the ER every day.
Every day.
So as we start to do these things, learning how to go down to the floor and get up and just different things. So, Stefan and I were talking about something and we were saying, when's the first time that someone should really start seeing a primary care doctor and why are they waiting so long? And I know we were talking about it. And
They're probably scared. There's a lot of fear out there, because people aren't getting really good care for the most part. They've probably been burned out from seeing providers, and so they don't go. And to be honest, I don't blame them. I've worked in internal medicine, I worked in family medicine, and for the most part, it's a mill. You're just trying, especially as a PA and nurse practitioner, they expect you to see a lot of patients in the day, right? We are revenue drivers for the industry, right? They can pay us a little bit less. Our job is to see the numbers. And you somehow have to also counsel the patient on diet, lifestyle, exercise, interpret labs within about 15, 20 minutes. It's just not possible in a regular primary care insurance-based office, which is why the DPC model is so much more beneficial, I think, for the American population, maybe the world population as well.
Yeah.
Because you get to spend that time with the patient and to come to a solution that isn't cookie cutter.
No, it's not. And it takes follow-up.
Yeah.
Which is why I encourage people the DPC model is so much more effective, because now you can see transparent pricing.
Yeah.
They can sign up, become a member, and maybe that 1 month they do have extra questions, so we're able to spend that time with them. And then over the course of the year, they get a well-balanced exercise plan, a diet, all these things change. We can continue to follow up with labs, and we never have to say, sorry, your insurance won't pay for it.
Never.
That was a terrible feeling.
Oh, terrible.
Right.
Oh, your insurance only covers the labs once a year. I'm sorry, we can't order this lab again.
But take this pill.
Take this pill.
Yeah.
Oh my goodness.
So we both spent years in that industry. I respect it because it is a very large movement. It has changed over the years. I think that if you go back to the original philosophy of the doctor who used to come to the home, once again, DPC, because there was no insurance, right?
Right.
So it created that connection. So, the DPC model is kind of a return to where medicine was, but using the high-end labs that we now have, using the knowledge and the computer systems, which can now calculate almost like AI type data, really, where patients can know the minerals, the fat content in their diet by simply taking a picture of it. So it's really gotten very special, and when you have somebody who understands that, I think that's what Stefan brings to the table so much, is that, I've seen you with the diagnosing, and you were just saying, sometimes you can even go in and just look at someone's meal plate, their house, their food, and you already know where they're depleted.
I already know, I really don't need labs for the most time to tell me if a patient is deficient in B12. I just go look through their fridge and I look at their nutritional profile in their fridge. That tells me better than most tests,
right,
where they're lacking nutrients, where their cardiac risk is, right, where their metabolic syndrome risk is, where their hypertensive risk is. I'm like, okay.
Thank you. I'm glad you said that.
It's
I love
right
hearing
here.
it. There it is.
You just look at the ingredient list.
Yeah. You don't need an ACE inhibitor right now. What we need to do is get you on some food, get you exercising. And I know the overall medical wants to do that, but sometimes with the restraints of the inability to spend the time with the patient to follow up on those lifestyle behavior changes. Lifestyle behavior change is the hardest thing to have someone, to encourage someone to do. So it's a tough.
It's tough, but it will save your life.
It will, and it'll save your children's life, your grandchildren. It'll create a legacy.
Sure will.
Of health. Yeah.
I mean, there's a lot to that statement. I mean, epigenetics, that is huge. How what you're doing, what you're putting in your body every day can affect generations to come.
Yeah.
And if you just think of it from that perspective, I mean, gosh, do you really want to put that Dorito and vodka in your mouth today?
So we always hear that, in the modern world, that health has increased, and antibiotics did have a lot to do with that, with some of those bacterial infections that were, really changing. And so one of the things, though, that is not a positive, though, is that heart attack risk has increased over the years. So actually, back in the time of the farming and eating more of a natural diet, before we had this change in our food products that can last for so long, more of this, sustaining food line that's come now to smaller producers, the heart attack age has actually gone down. Now, something scary, many of us, without primary care, without someone like us, they may not see these markers. So what would be the marker for someone out in the world that they have a heart concern? It's a raging heart attack.
Yep.
It's a raging heart
That's
attack.
usually the first First indicator that
With a
you
50% first survival rate. That's just not good odds.
that's
you know?
bad odds.
Yeah. Added to the trauma to the heart, which maybe, you know, ischemic attack can leave permanent damage.
The heart muscle doesn't come back.
Yeah. So there's some concerns, and this is why we were talking earlier and just saying we really wanted to share with people, just to get the word out, that young people, 20s, you need to be signed up with a direct primary care. You need to be signed up with a primary care who's going to look at your lab work, evaluate your food, get you on track. Because the worst thing you want to do is then go into life with your 2, 3, 4 kids, you know, as ever blessed as you are, however many kids that show up. And then all of a sudden you're scrambling just to survive. Your stress is through the roof. 10 years go by, you're on the same poor diet you had, you know, pizza and beer on the weekends for football.
Yeah.
And then you get that wake-up call. And it can be too late sometimes.
For most people, I mean, I guess half of people who end up with that, it's too late for them.
Yeah.
So yeah, you want to start early. I'm seeing it even younger. So I work with pediatrics as well, and fatty liver disease among children. This was a disease that was thought to only happen to obese older adults. And I'm seeing trends now. The number one reason for liver transplant is not alcohol, it's not hepatitis C, it's fatty liver disease.
Right.
Can you imagine that?
Right.
And you can change fatty liver disease with just diet and exercise. There's no pill for it.
No.
It's an epidemic.
Just eat good food.
Just eat good
Eat
food.
good food. Exercise.
And you can avoid a liver transplant.
Yeah. You know what I always think of that too? Is that so many people are resistant to this, but they've been tricked. They're getting that satiety. They're getting that feeling from the food they eat because it's more of a neurotransmitter response. But what they don't realize is how much better they could feel. They go day in and day out really depressed, tired, lack of energy, just not feeling positive. Where if they're eating the right diet and exercising, they'd be, you know, you'd have increased serotonin, you'd have decreased depression, you'd have more energy.
That neurotransmitter thing is so important, right? So doing what we're trying is hard. It takes longer. But if you can go into the kitchen and you can get that hit of dopamine in the form of maybe that bagel, that donut, that makes you feel good temporarily though, right?
Yeah.
And so if that helps you, why don't you just do more of that? Get more bagel, get more donut, and you keep going for those serotonin hits. Like watch the TikTok again. Gives you that hit, right? It's like a drug. So in our society, we are hit with these chemical rushes to our brain all the day. I mean, forget like cocaine, forget heroin. We're going for the quicker hits in the fridge. Sugar. The quick, easy processed carbohydrate. The fried chicken.
Yeah. And it's leaving a mark. It's leaving a mark on a country such as America, which is spending high value health dollar, but possibly, you know, with some of the metrics not seeing the best results because we're in the bottom third of industrialized nations right now. So there's a lot of questions. I do think that there'll be a lot of change, and the most important thing is really primary care right now. And I know you and I talk about this all the time, so we just can't get it out enough. But you know, with something like Iron DPC, where we're looking at the whole person,